Overdiagnosis is causing millions of adults over 60 to undergo unnecessary cancer screenings. And these 5 medical tests might be doing you more harm than good. If you're 60, 70, or 80 years old, your doctor might still be recommending tests that leading medical organizations now say you should think twice about. I know this sounds alarming. For decades, we've been told that more screening is always better. Get your annual physical, schedule that mammogram, don't skip your PSA test. But here's what's changed. We now have overwhelming evidence that some of these tests can cause serious harm through overdiagnosis and overtreatment, often without providing any meaningful benefit. Overdiagnosis happens when screening finds conditions that would never have caused problems during your lifetime. But the discovery leads to treatments that absolutely will cause problems. Dr. Say Lee from UC San Francisco puts it bluntly, we find something that wasn't going to hurt the patient, and then we hurt the patient. Let me share some numbers that might shock you. The American Cancer Society acknowledges these estimates. We're talking about millions of people undergoing surgery, radiation, and chemotherapy for cancers that would never have threatened their lives. The first test I'd avoid after 60 is the routine annual physical exam for healthy adults. I can hear you protesting already. But my doctor says I need my yearly checkup. Here's the reality. Major medical organizations now recommend against routine annual health checks in adults without symptoms. Dr. Ativ Mehrotra from Harvard concluded that exams don't improve health outcomes. Dr. Ezekiel Emanuel agrees. If you're healthy, there's every reason to believe these visits make no difference. This doesn't mean you should never see your doctor. If you have symptoms or ongoing conditions, visits remain essential. But the idea that healthy people need a battery of tests? The evidence simply doesn't support it. What's concerning is that these physicals trigger unnecessary testing, a cascade of care that can spiral out of control. A slightly abnormal result can unleash weeks of anxiety, additional procedures, and real medical complications. The second test to reconsider is PSA testing for prostate cancer in men over 70. The task force explicitly recommends against PSA screening for men 75 and older since 2008. Here's why. The PSA test has a false positive rate close to 50%, and it's even higher in men over 70. Dr. Stephen Purcell explains, you won't save his life, but you will subject him to the potential harms of treatment. About 80% of men aged 70 and older with prostate cancer have slow-growing, non-lethal types. Treatment can result in permanent incontinence, erectile dysfunction, and bowel problems. One urologist told me about an 85-year-old patient whose biopsy caused a life-threatening infection. That man spent his remaining years dealing with complications from a test he never needed. Despite guidelines, 55% of men 70 to 74 still get PSA tests. Nearly 40% over 80 continue screening. The third test is mammography for women over 75. The task force says there's insufficient evidence after 75. The overdiagnosis problem becomes extreme. In women 75 to 84, it jumps to 47%. And for women 85 and older, 54% of detected cancers would never cause symptoms or harm. Dr. Laura Esserman argues we're not being honest. Most people are completely unaware of the risks. We've had 40 years of a messaging campaign. Go get your mammogram and everything will be fine. The emotional toll is significant. False positives lead to callbacks, biopsies, and weeks of terror. Nearly 1 in 5 women with severe cognitive impairment, including dementia patients, are still being screened. The fourth problematic test is colonoscopy for adults over 75, particularly those over 80. After age 75, the risks of perforation and bleeding from colonoscopy double compared to younger patients. Complications from anesthesia increase from 26 per 1,000 procedures after 65 to 35 per 1,000 after age 80. The crucial point is lead time bias, the illusion that finding cancer early always helps. While screening in your 50s extends life by 10 months, in adults over 80, the benefit drops to just 1.5 months. Dr. Deborah Korenstein explains, it generally takes about 10 years to see benefit from cancer screening. If you're 82 and in poor health, are you likely to live long enough to benefit? The math often doesn't work out. The fifth test to question is cervical cancer screening for women over 65. Current guidelines recommend stopping Pap smears at age 65 for women who have had adequate prior screening. Cervical cancer develops very slowly from HPV. After 65, the chance of it developing is extremely low. One study followed over 2,500 postmenopausal women and found only one minor abnormality. But that screening generated 112 additional tests and multiple invasive procedures to investigate false positives. Now, I want to address the elephant in the room. But what if I'm the exception? What if screening would save my life? These recommendations are based on population-level evidence. For most, the harms outweigh the benefits. Dr. Ilana Richman explains, we don't want patients to think we're giving up on them. It's the opposite. What we're after is care that improves quality of life by avoiding tests that are unlikely to be beneficial. Start by having an honest conversation with your doctor about your life expectancy and personal values. If you're 75 and running marathons with a family history of longevity, the calculation might be different. Ask your doctor, what is the number needed to screen to save one life? What are the chances of finding something treatable? What are the risks of the screening? What are the chances of a false positive? How long do I need to live to benefit? Stopping screening doesn't mean ignoring symptoms. New bleeding, lumps, or pain always need evaluation. The broader issue is that American medicine has become addicted to testing. More is always assumed to be better. Dr. Yul Anas acknowledges, the delivery method used for decades may not be as effective as we think. The Choosing Wisely campaign has identified dozens of tests that are overused. The goal is to focus on outcomes. This represents a fundamental change. Instead of asking, why shouldn't I? We need to ask, why should I? The burden of proof has shifted. Tests need to prove they provide net benefit, not just find something. If you have advanced heart disease or other serious illnesses, slow-developing cancers may not be a priority. Many of these tests are expensive. When the medical benefit is questionable, the economic burden is hard to justify. This isn't about rationing care based on age, it's about life expectancy and overall health status. Adult children often push for more care. Share the research with them, show them avoiding tests is the healthier choice. The medical community is catching up, but change is slow. Doctors worry about malpractice or tradition. Don't be surprised if your doctor resists. Come prepared with information about current guidelines. A good doctor will appreciate your engagement and work with you to make evidence-based decisions. Looking ahead, we'll see more personalized approaches using genetic testing and AI. But for now, age and overall health status remain our best guides. Reaching 70 or 80 doesn't mean you need more tests. The goal of healthcare at any age should be to maximize healthy, meaningful years of life. Medical care should be based on evidence, not fear or tradition. Focus on preserving your quality of life. The most important screening might not be a medical test at all. It's honest conversations about your values. Questioning these screenings isn't giving up. It's about being smart with your health. Sometimes the healthiest choice is saying no. So what does all of this mean for someone trying to make sense of years of medical advice that suddenly feels less certain than it once did? What it means at its core is that medicine is slowly admitting a hard truth. Doing more does not always lead to better outcomes. And ordering more tests does not automatically protect health. For many years, the system rewarded action over restraint. Tests felt reassuring, procedures felt responsible, and saying yes felt safer than saying no, even when the benefit was unclear. The result was a culture where activity replaced evidence, and caution often took a back seat. With age, that imbalance becomes harder to ignore. The body tolerates procedures less easily, recovery stretches out, complications carry heavier consequences, and anxiety lingers longer. Time itself becomes a limiting factor, which means a test that made sense at 50 can lose its value at 75. The trade-off changes, and that shift matters. This is why medical guidance has begun to move away from automatic screening and toward decisions based on the individual. The change is not about caring less for older adults. The change reflects a growing understanding that caring well requires judgment, not routine. Care after 60 is no longer about uncovering every possible abnormality. The focus shifts toward maintaining function, protecting independence, and reducing avoidable harm. Comfort, mobility, and daily quality of life start to outweigh the pursuit of unlikely diagnoses. That shift also demands a different way of thinking. Instead of assuming a test is helpful until proven otherwise, the burden now rests on the test itself to show that it improves outcomes that actually matter. Longevity, comfort, and freedom from unnecessary intervention carry more weight than detection alone. Fear complicates this process. Cancer screening, especially, carries emotional force. The idea of missing something feels unbearable. Even when evidence shows that many findings would never cause harm, fear pushes decisions toward action, but action without benefit often creates damage that cannot be undone. When screening uncovers conditions that would have remained silent, the result is rarely peace of mind. What follows is often years of surveillance, invasive treatments, and a persistent sense of vulnerability. Overdiagnosis does not stay on paper. It follows people home. Many older adults are already balancing several chronic conditions. Heart disease, diabetes, lung problems, arthritis, and cognitive decline shape daily life far more than a slow-growing cancer ever would. In that context, chasing unlikely threats can distract from managing the problems that already demand attention. Screening choices should reflect that reality, which is where honest conversations become indispensable. Quick appointments and automatic orders leave no room for nuance. Thoughtful discussions about life expectancy, overall health, and personal priorities do. Values matter. Some people prioritize longevity above everything else. while others value independence, comfort, or avoiding invasive care. Different priorities lead to different decisions, and neither approach is wrong when it is informed and deliberate. Family pressure often complicates these choices. Adult children may equate more testing with better care, believing that insistence shows love. Declining a test can feel like surrender, even when evidence suggests it is the wiser path. These conversations are difficult, but they are necessary. Medicine itself is still adjusting. Many clinicians trained during an era when more testing was considered best practice. Others worry about legal consequences or patient dissatisfaction. Change moves slowly, even when data points in a new direction. Efforts like the Choosing Wisely campaign exist because overuse has become impossible to ignore. The goal is not to deny care, but to direct it toward interventions that improve lives rather than complicate them. Restraint, when guided by evidence, reflects care rather than neglect. Looking ahead, screening may become more precise as tools improve. Genetics, biomarkers, and better risk models may one day clarify who benefits and who does not. For now, age, overall health, and time to benefit remain the most reliable guides available. The message is not that screening is harmful by default. The message is that screening is context-dependent. Timing matters, health status matters, and expected benefit matters. Reaching 60, 70, or 80 does not automatically justify more testing. In many cases, it calls for fewer tests and more conversation. Medicine works best when decisions are shared, thoughtful, and grounded in evidence, rather than habit. The purpose of healthcare has never been to identify every abnormality. Its purpose is to help people live longer when possible, live better when longevity cannot be extended, and avoid unnecessary suffering along the way. When a test no longer serves that purpose, declining it becomes a rational choice. Choosing less can reflect clarity rather than avoidance. Sometimes the most protective decision is not to act reflexively, but to pause, evaluate the evidence, and decide deliberately. That approach does not signal indifference, it signals informed care.